I'll put my camera on a little bit more. Hi guys, I'm Cameron. I'm one of the F2s over in Grimsby currently, and also help run the pre-hospital care program at HIMSS. And I was an ex-HIMSS student, so I just thought it'd be good to put together a little bit of a teaching series about the acute care block. I'll just share my screen as well. Hopefully you can see that. Can you see that, Carolina, the screen?
Yes, you can, yeah.
You can, brilliant. And you can see the slides?
Yeah.
Perfect. Yeah, so I thought it'd be good to just put together a little revision series aimed at the sort of 4th and 5th year students around the acute care block that you get with HIMSS. I appreciate the 5th years have probably got their exams in a couple of weeks. But it'll be good for definitely good for the 4th years with the revision in full flow, I'm sure. So it's going to run over the next few weeks until sort of mid-April, and I've put together these topics that I hope will cover a lot of the stuff that's in the acute care block that's not covered in other blocks. So make sort of like the acute respiratory stuff is covered in your respiratory block, like your pneumothoraxes and things. So that will be covered over there. But I just thought the other bits and bobs that are covered just in the acute care block will be useful to cover because it does come up in exams. So today we're going to be talking about poisonings and overdoses, which are really, really, really easily examinable questions because essentially a lot of the questions they can ask are just tick boxes, single answers, very factual, very, very easy to ask questions on. So I thought I'd start with a bit of an approach to the poisoned patient in general. So not specific to any particular drug, but just any patient that comes in with an overdose. What's the approach? As for every single acutely unwell patient, it's going to be an A to E assessment, which I'm not going to go through in this lecture. IV access, bloods, including your VBG, particularly to get your lactate, your electrolytes, your pHs, which will come up in some of the drugs that we'll talk about later. Tox space is your best friend, not so much in exams because you don't get it, but definitely in clinical practice, particularly if you've got an A&E job, tox space is your best friend. Often the nurses will kindly print it off for you and put it in the patient's notes, and that gives you a really good basis of investigations to order, any special tests to do, and then your management plan. ECG is really, really important in every single poison patient because of the ECG changes you get with lots and lots of drugs. Remember to check glucose. They might not have come in with an overdose or been poisoned. It might just be because their glucose is low, so don't forget the basics. I put lorazepam as a question mark. Obviously, you can have an overdose of lorazepam, but lorazepam will be really important if you start to get seizures as a result of the poisoning. Think about your antidotes. I've got a little table towards the end that you can screenshot that's just a very, very simple poisoned and what the antidote is. Make sure you fully examine your patient, obviously, and then always remember that psychiatric assessment at the end. That's a great health and society question that comes up. I think we had one in one of our mock exams around sort of the approach to the poisoned patient and the type of things you would ask and look for from a psychiatric point of view. Just another couple of key points. The National Poison Information Service is really, really good to go for information and help, particularly out of hours in a practical sense. You can ring them at 2 a.m. in the morning. There's an on-call toxicology consultant to ring if you are a little bit stuck. If you get to a point where you're in a cardiac arrest due to poisoning, generally you would keep the arrest going for around an hour before thinking of stopping. So that's just a really basic approach to the poison patient in every single one. Okay. So these are the things we're going to cover in this sort of half an hour, 40 minutes. So it is a lot. There are lots of drugs here. So I'm going to focus mainly and in more detail on the ones that are A, more common, and B, come up in exams more often. So that's the ones up at the top here. And the ones down here I've sort of summarized in 1 or 2 slides because it's more just remembering the key bits of information rather than actually understanding the concepts just for exams. So a little bit of a case study. You've got a 21-year-old female. She weighs 70 kilograms. She's known to have depression. She's currently taking citalopram. And 2 hours ago, she told you when she came into A&E by the ambulance that she took 15 paracetamol tablets all at once. So within the hour. So just have a little think from if you're doing your PSA about how much paracetamol she's ingested in milligrams per kilogram. And we'll talk about the answer in a second, unless anyone wants to shout it out whilst you've got your calculators going. How much paracetamol has she ingested in milligrams per kilogram? And if anyone wants to shout out any next steps you want to consider as well, by all means go for it. Any thoughts? So she has ingested 107 milligrams per kilogram. So you would obviously times the 500 milligram tablets by 15 and then divide it by 70 to work out how many milligrams per kilogram. So it works out 107 milligrams per kilogram. Next steps, with paracetamol overdose patients, a couple of questions you need to ask is how much have they taken, which we've established here, and how long ago you've taken them, because that will guide some of your investigation and management. So just touching on a little bit of physiology with paracetamol. Up at the top, you may very well have seen this before. The top infographic shows what normally happens with paracetamol and how it's excreted. So you get it is conjugated and then excreted in the urine. Some of the paracetamol forms this NAPQI, which is then sort of conjugated with glutathione, which then forms a non-toxic metabolite, which is then excreted. However, in paracetamol overdoses, this pathway is saturated, so you get lots and lots of this, particularly hepatotoxic NAPQI, because the glutathione, there's not enough of it for it to form the non-toxic metabolite. Hence, you get lots of hepatotoxicity with it. Clinical features, to be honest, much like lots of poisonings, is very, very vague, often asymptomatic, and they may just complain of some abdominal pain and nausea, vomiting. Often with paracetamol overdoses, you will know, either they will come in and tell you, or they will have been found with sort of packets of paracetamol, for example. The other thing to note as well is, particularly paracetamol, it's not just intentional overdoses. We can have therapeutic overdoses of paracetamol, particularly on the wards at work. It can happen. So yeah, this is just a note of the toxic amounts, unlikely to come up in your exams, but just a little note. So with your starting treatment in paracetamol overdoses, you'll have all seen the paracetamol treatment graph, which I'll show shortly. And the plasma concentration's got to obviously be above that treatment line. But this is the criteria for when we start treatment. So obviously, if it is above the treatment line, if you're within 8 hours of ingesting more than 150 milligrams per kilogram, and if there's going to be a delay of more than 8 hours in getting this paracetamol level, unlikely, if I'm honest, but given delays in A&E departments, potentially you might get that. If someone's presenting between 8 and 24 hours after ingesting a really large amount, then you would just start the treatment without bothering to measure the paracetamol level. If the amount ingested is unknown or the patient is symptomatic, so they've got features of hepatic encephalopathy, abdominal pain, jaundice, etc. If you've got a patient that's presenting more than a day after ingestion of a really large amount, again, just start treatment without bothering with the paracetamol levels. If you've got the biochemical tests, which indicate someone's got an acute liver injury, then you would start the treatment. And the most important one that comes up in exams is anyone that's had a staggered overdose. So staggered overdose is anything where they've taken the drug in more than a 1 hour period. And acute overdose is everything within an hour. Staggered is sort of longer than an hour. This is the treatment graph you'll have all seen. You need to take the paracetamol level if you're not treating at 4 hours, not before. And ideally, you want to take it within 15 hours because after 15 hours, it doesn't become as accurate, but needs must. And obviously, if your paracetamol level then comes back above the treatment line somewhere here, then you would start the treatment with NAC, which we will touch on. So this is the dosing regime for acetylcysteine, which essentially just restores those glutathione reserves, which ensures that NAPQI goes into that non-toxic metabolite. This is the SNAP protocol. So this is the generally recognized protocol for paracetamol overdoses. You give the first infusion over 2 hours and the next infusion over 10 hours. You then check the liver function, and then you can look at the extended dosing. This is a little bit of a complicated graph that I've taken from one of the policies, but if you read it, it is quite self-explanatory. So this is looking at whether you need to give your extended bag or not. So after you've given the second bag, you need to do your LFTs and your coagulation screen. If they are deranged, then you would give the extended treatment, essentially, which you can give then another 2 bags. So that's just a summary, basically, of all of what I've just said. The key bits down on the bottom right-hand corner is if the patient's got severe acute liver injury with any of those features, they need discussion with the hepatology team and potentially the transplant centres, whether they need an urgent liver transplant because of the hepatotoxicity. So that's your paracetamol overdoses. So it's a bit of a whistle-stop tour, but NAC is the most important antidote for your paracetamol, and it's worked very, very, very well. I've never had anyone that's become poorly after having NAC as such, with it not working. So this is another clinical case. So we've got a 60-year-old male. He's just come back from theatre, having had a left hemicolectomy. He's quite drowsy, and he's snoring on the wards. And the nurses have rang you and saying his respiratory rate's 6, and he's not really responding to them. So you assess him, and you're right, the respiratory rate is 6, and he's got pinpoint pupils. Unfortunately, the anaesthetic drug chart isn't at hand. It's been left in theatres. Any initial thoughts about what's going on with this patient?
So with it being pinpoint pupils, would it be an opioid overdose?
Yeah, opiate overdose. Like I say, it's not just those that have taken the overdose intentionally. This is a really, really common scenario. I had one on my night shift last week. A patient come back from theatre, really, really drowsy, who just had a little bit too much opiate in theatre. So yeah, opiate toxicity. So what are we actually aiming for when we're treating opiate toxicity? Any thoughts about what's the goal of treatment?
Prevent respiratory depression increasing.
Yep, brilliant. That's one of them. So the respiratory depression is one, and the other important one is the oxygen saturations and maintenance of airway reflexes. The Royal College of Emergency Medicine puts a highlight saying that the goal is not full reversal of consciousness. So actually, it doesn't really matter if the patient is a little bit drowsy, as long as their respiratory rate's okay and they're maintaining their airway reflexes, then they're probably okay. We don't need to start giving them loads and loads and loads of reversal just to reverse their lack of consciousness level. So this is really important. Your respiratory rate greater than 10, no two sats greater than 92. That's your target. If they're doing that and they've got airway reflexes, then probably just leave them be. This is taken directly from the Royal College of Emergency Medicine guidelines. So if you want to screenshot it or use it for revision purposes, then by all means do that. It's a really, really good, simple flowchart that just talks you through the process for opiate overdoses. So if you're in this category here, which is the one that we were in, respiratory rate is as 6. Apply some oxygen, and you can give them some IV naloxone. So the naloxone is the obviously opiate antagonist. Give around 100 to 200 micrograms initially, and then you can just repeat that every minute up to 2 milligrams, aiming for that target of increasing the respiratory rate. If then they deteriorate after an initial improvement, you can do exactly the same again, 100 to 200 micrograms every minute up to 2 milligrams, aiming for that respiratory rate of greater than 10. If you're doing this, if you're repeating doses after an initial improvement and then a subsequent deterioration, the patient will then require a naloxone infusion. The naloxone infusion really isn't very important for exams at all, but it's good to know, particularly when you've finished med school. It's really important to know that. If you're in a respiratory arrest situation, you will just give a slightly higher dose of the naloxone at 400 micrograms. Then you can give 800 and another 800, as well as ventilating the patient with the bag valve mask. And they will more than likely then need a naloxone infusion as well. So again, this is really not that important for exams, but I just thought I'd pop it on here just as a good to know slide. If you, like I say, if you're getting to the point where you're needing that second cycle of naloxone, the infusion is set up at 60% of the total dose that you needed to reverse the respiratory depression during that second cycle. So, for example, obviously, if the initial bolus was 600 micrograms, you would then start the infusion at 360 micrograms per hour. The way you constitute it is 4 milligrams in 30 mils of sodium chloride. So that's 10 400 microgram vials. So the entire thing will be 40 mils. Anyone want to have a go at what the concentration would be in that for you, if you've got a sort of PSA question? What's the final concentration in that mixture from the naloxone infusion? Okay. So it's 100 micrograms per mil it works out at. So you've got 4 milligrams in 40 mils of solution, which is, if you divide that down, works out around 100 micrograms per mil. Classic PSA question. Right, let's move on to some digoxin toxicity. So I appreciate we're sort of going through these quite quickly, and there's going to be quite a lot of drugs we're going to talk about, but I think it's good to know for exams. So, bit of digoxin. You'll all know the pharmacology of digoxin, so I'm not going to harp on a little bit too much about that. But it's a sodium potassium ATPase inhibitor, which results essentially in increased force of contraction of the cardiac myocytes, which obviously used to treat things like atrial fibrillation. Obviously, the key points, you will all know that it has a really narrow therapeutic index. It's eliminated in the kidneys, and some of the drugs on the right-hand side there are things that will increase your digoxin levels. So just be aware of those when they come up in the exams. They're really easy exam questions. Those are the drugs, if they're given concurrently, can increase digoxin toxicity. Clinical features. We tend to split these into acute and chronic. Acute overdose, really, really vague again. arrhythmias, nausea, vomiting, like every other drug. With your chronic overdose, the classic ones you see I've highlighted, which is your sort of alterations to your colour vision and this yellow vision that you get, which you'll have seen in the textbooks. That doesn't happen with acute overdose. That only happens with chronic overdose. So just be careful. Again, like you can see that they're all very, very vague clinical features. ECG is really, really important. Particularly with digoxin, it can cause virtually any arrhythmia. You'll see in the textbooks about this digitalis effect. It's really not very common at all. They describe it as a reverse tick sign with this inverted T wave when you shorten QT and this ST depression. But I've never seen it. They will just have sort of any arrhythmia. The other arrhythmia, another classic association with digoxin is this bidirectional tachycardia, which you can see on the top of the screen. You can see that the R waves are going up, and then you get a deep Q wave. But again, not very common. I've never seen it. And management of digoxin toxicity is with Digifab, the specific antibody. I'm not going to bother going through the doses, but that's the key one for exams, your Digifab, your antibody. So moving on, another case study. We've got a 25-year-old male this time. He's come in sweating, he's hyperventilating, he's got tinnitus, and he's complaining of vertigo as well. And he said he's taken some of his mum's tablets with a view of ending his life. I've popped the arterial blood gas up there. Anyone got any thoughts about what is going on? What drug is it? And anyone want to talk me through the ABG?
Is it aspirin overdose?
Why is it aspirin overdose?
I just know that tinnitus and hyperventilation are symptoms of it. That's all I can go off.
Yeah, no, they absolutely are. You're correct. It is aspirin overdose. Tinnitus and vertigo is the classic one you'll see in exams and pass med and that sort of stuff. So you are correct. What about the ABG? Why have I put the ABG up there? What's another classic association with aspirin?
I'm guessing they become very acidotic.
So they do become acidotic. What type of acidosis do they have? Respiratory or metabolic? So aspirin is one of those, you get a bizarrely mixed picture. You'll get a metabolic acidosis with a respiratory alkalosis. So you mentioned the hyperventilation, and because of the hyperventilation, you will thus get a respiratory alkalosis because you're blowing off all your carbon dioxide. Hence, the carbon dioxide here is low. You will also get a metabolic acidosis. Hence, the bicarb here is low. So you may very well, the pH may very well be alkalotic or acidotic, depending on which the shift and how acidotic or alkalotic they are. But you get a mixed picture with aspirin. And you will get a high anion gap as well. So this goes to you'll all have seen the mud piles sort of mnemonic before about causes of high anion gap metabolic acidosis. Your anion gap being your positive electrolytes versus your negative ones. So your sodium, potassium minus your bicarb and chloride. And the salicylates, which aspirin is one of the high ion gap ones. So yeah, as I mentioned, you get this respiratory alkalosis and then this metabolic acidosis just due to a buildup of lactic acid. And you get the classic features of tinnitus, tachypnea, sweating. You get some glucose abnormalities as well. Treatment of salicylate overdose is generally supportive, unless they've taken an extremely large amount of aspirin. It's generally just supportive. We can use something called urinary alkalization, which you'll have heard, which essentially means giving a really high concentration of sodium bicarbonate. And what this does is the theory is that the ionization of this weak acid, which the salicylate is increased in an alkaline environment. Thus, in the ionized state, the aspirin can't be reabsorbed across the tubular epithelium. Thus, you just wee it out, essentially. So that can be used. In very, very severe cases, we can just use hemodialysis and just get rid of the aspirin. It's very effective, but generally only in very severe cases. So moving on, we've got a 30-year-old male this time. He's taken an overdose of his mum's tablets he's used for pain for her back. Wanted to end his life. He's complaining of sweating, fast heart rate, dilated pupils, dry mouth, and is very, very drowsy. And this is his ECG. So what are your thoughts with this one? What drug are we trying to push at you?
Benzodiazepines.
Why do you think benzodiazepines? What's your thoughts? Could be.
I was just thinking sort of sedation, being drowsy.
Yeah, benzodiazepines absolutely will make you very, very drowsy. This isn't benzodiazepines. This is tricyclic antidepressants. Drowsiness is very, very common in lots of overdoses. Benzodiazepines being one, tricyclics being another. This is highlight the stem there is highlighting that she's probably on something like amitriptyline for her neuropathic pain, which is a more common use of tricyclics now rather than actually for depression. You get this anticholinergic effect, so you'll have seen the mnemonic "can't we," sort of can't see, so you get blurry vision with the dilated pupils. You get a really dry mouth because you're not producing saliva. And the ECG, does anyone want to talk me through the ECG? So you can get a widening of the QT with tricyclic antidepressant overdoses, and you can see that there's this really, really big T wave as well. Tricyclics generally very, very toxic, and that's why we don't use them very often now. But they block sodium channels on the myocardium as well as the potassium channels. So that's where you get most of the toxicity from, this cardiac toxicity. The other effects that you will get, such as your muscarinic side effects and things, are less important from a toxicology side of things, but you will get those side effects. Again, management of tricyclics, IV sodium bicarbonate, similar to the sort of urine alkalization, reverses the acidosis. If the patient is intubated, we tend to hyperventilate them to get rid of some of that acid. And glucagon can be useful in persistent hypotension. I'm not sure why in tricyclics, but the most important thing to know about tricyclics is the sodium bicarbonate as the antidote. So benzodiazepine overdoses, I will just very, very quickly run over this because there's not a great deal to it. You do get drowsiness, you get dysarthria as well, and very rarely you will get respiratory depression. The respiratory depression often comes if the patient has taken things like alcohol with the benzodiazepines as well. They may get that, but benzodiazepines on their own don't tend to cause respiratory depression. Management of them, again, generally we just observe them. There's talk of this flumazenil, which is the antidote that comes up in exams, which is a GABA agonist. In intentional overdoses, so patients that have intentionally taken benzodiazepines and come in, say, through the A&E department, we don't tend to use flumazenil. We tend to just let them sort of ride it out, just observe them, make sure they're maintaining their airway, rather than reversing it, because you can get some quite bad withdrawal side effects if you're using the flumazenil. You'll see the flumazenil used generally in therapeutic overdoses, so in ICU or in A&E. If we've given too much benzodiazepine for some sedation, you may very well see that used to reverse it, but not so much in the intentional overdoses. So moving swiftly on, we've got another case study, a 55-year-old male this time. He's been receiving treatment for an unspecified mental health condition. Been taking the medication for years, but he's missed his last few checkup appointments. He's got a bit of a tremor, quite agitated, and you note on examination that he's got hyperreflexia. Any thoughts on what this one's pointing towards?
Maybe serotonin syndrome.
Could definitely be serotonin syndrome, actually. It could. SSRIs, tremor, hyperreflexia, absolutely could be. It's not the one I've gone for, but that is a 100% valid answer. It could be serotonin syndrome.
Is it lithium?
It's lithium, yeah. The one I'm going for is lithium, but yeah, you're right. It could be serotonin syndrome with the with the information I provided. But I've gone with lithium. Missed the last few checkup appointments. Lithium's got this very narrow therapeutic index. With serotonin syndrome, if the patient's just on a single, say, SSRI, sort of citalopram or something like that, it's very unlikely they will get serotonin syndrome. You only get it if either it's mixed with other drugs that can then cause, you've got an additive effect, or there's a drug interaction. But lithium is very, very toxic, has had this very narrow therapeutic index. This always comes up in exams for whatever reason, this precipitance to lithium toxicity. Hyponatremia is the one that I've seen most often. So if you've got a patient that's, say, been refusing their eating and drinking, they're really dry, they may then develop this hyponatremia because they're dry, which then will precipitate the lithium toxicity. Renal failure, diuretics, because they cause hyponatremia. ACE inhibitors and NSAIDs as well, because of the renal, the effect the kidneys, thus reducing the clearance of the lithium. It does always come up in exams, that one. So in acute overdose of lithium, it's not as common actually. You mainly just get some GI symptoms. You're very, very unlikely to get the symptoms of the neurotoxicity, such as your tremor, your hyperreflexia. So if those are present in an acute overdose, the guidelines say to consider an alternative diagnosis. For an acute overdose, the treatment is just forced diuresis, just to get them to wee the lithium out, essentially. The chronic overdose is the most important one to remember for your exams. You'll get those classical symptoms, your neurotoxicity symptoms. Management, again, is generally supportive. We don't give activated charcoal in those patients, mainly because it doesn't work. If there is neurotoxicity or renal impairment, the patient will need hemodialysis to get rid of the lithium, because the kidneys won't be able to. So that does come up in exams. Another case study. So we've got a 65-year-old female this time. She's taken an overdose of the drug the doctors have given for her fast heart rate for her overactive thyroid gland. Her heart rate is 25. Blood pressure is 80/60, and she's drowsy, being responsive to pain only. So what are your thoughts on what drug's going on here, and any ideas on how you would manage, or what's the reversal for this patient? Any thoughts?
Likely overdose from propranolol.
Perfect. Yeah, propranolol, beta blocker overdose. Any thoughts on how you want to manage the patient? What's the antidote for what drug do we give in beta blocker overdoses?
Would you just maybe give atropine or glucagon?
You would give both. I would give both. Why are you giving the atropine? What's the atropine for?
The bradycardia.
Yes. What does it do anything else? Or does it just treat the bradycardia? It's not a trick question.
Probably yes, but I couldn't tell you why.
No, it doesn't. The reason you're giving the atropine is just for the bradycardia. The glucagon is the drug you're giving to sort of help with the toxicity as such, which we'll touch on. You're right. You get a profound bradycardia and hypotension with beta blocker overdoses and calcium channel blocker overdoses. They work in a similar way, to be honest. Of note, the propranolol also is a sodium channel blocker, so you will get this long QT. You get ventricular arrhythmias with it as well, so just be careful. And the sotalol, you'll know, is also a type 3 antiarrhythmic, so it also blocks potassium channels, so you can also get this torsades dipor ECG. Atropine, as we mentioned, is just for the bradycardia. So we're going to cover arrhythmias tomorrow. So we'll go through atropine and some of the other arrhythmias. The glucagon is the most important one, aside from the atropine. You give quite a high dose. So normally glucagon just comes in 1 milligram vials, but here you're going to give 5 to 10 milligrams IV, and that actually treats the cardiac toxicity by activating the myocardial adenylate cyclase. So that will prevent the other arrhythmias, but it can be quite difficult to get hold of. The one at the bottom, this high-dose insulin euglycemic therapy, is quite a new regime for beta blocker and calcium channel blocker overdoses. So this involves giving a really, really high dose of short-acting insulin. So you give 1 unit per kilogram, which for a 70 kilogram bloke is going to be 70 units of insulin, which is quite a lot. So you give that as a bolus with some background glucose to prevent them from going hypoglycemic. And the principle behind that is that it improves myocardial function, promotes contractility, and increases glucose and lactate uptake in the myocardium to try and reverse the cardiac toxicity. I've never seen it given, but looking on the RChem website, there was an article saying that it's a very, very effective treatment for calcium beta blocker overdoses, but nurses aren't very keen in giving it because you're giving the patient quite a lot of insulin, so it might take a little bit of convincing. Theophylline overdoses, just moving swiftly on. I'll just put this on one slide because it's not overly important, but it does come up in exams. Again, one of those drugs we don't use very often now because it's got such a narrow therapeutic index. It can cause toxicity within sort of 12, 24 hours just due to these modified release preparations, so please be careful. Clinical features, again, quite vague and non-specific: headache, convulsions, hyperreflexia. So your history is really important. What drugs are they taking on their normal medications for, say, asthma or whatever. Management is activated charcoal, regardless of the time of taking the meds, due to these modified release preparations. And again, symptom management and dialysis being the mainstay of severe theophylline overdoses to take the drug out. You're seeing a little bit of a theme, I imagine, is hemodialysis can be used for most overdoses, but generally is a last line resort. Iron poisoning, again, another important one that comes up in exams. This causes problems for a couple of reasons. So you get direct injury to the GI tract, so you can get things like GI bleeds, ulcerations, but it also then impairs the cellular function of the heart, liver, and central nervous systems by forming free radicals, leading to cellular death. So you get this metabolic acidosis, GI bleeding, you can get coagulopathy, cardiac arrhythmias. So it's not a nice drug at all in overdose. The things you'll see in the textbooks is that patients who aren't symptomatic after 4 to 6 hours of ingesting the iron don't require treatment because they're unlikely to have ingested a toxic amount of the iron. So that's just a note. Management: charcoal has absolutely no effect at all on iron, so don't bother. The main one to remember is this deferoxamine, which is just a chelating agent. So it binds to the iron, it takes it from the tissue and takes it from the plasma, and it's just excreted. So it's a really, really good drug. You give it a continuous infusion, that's 50 milligrams per kilogram per hour. You can do a whole bowel irrigation to clear the iron pills before they've been absorbed, but it's not very common. This one is the most important to remember for your exams. The ethylene glycol and methanol poisoning. You'll have probably seen in the news a few months ago. There was some tourists in Thailand, I think it was, that got methanol poisoning, unfortunately, from poor quality alcohol that they'd purchased. It wasn't ethanol, it was methanol they were drinking. It's very, very, very toxic. Between 20 to 30 mils of methanol or ethylene glycol can be fatal. And it's very, very difficult to treat because it acts so fast. Your ethylene glycol you'll find in antifreeze, so please don't go drinking antifreeze. But that's why you need to keep things out of the way of kids and things, because the smaller doses can be very, very toxic in children. 5 mils of ethylene glycol in children can be fatal. It's really, really important. They will appear drunk, similar to alcohol ingestion. They may very well complain of blindness and vision problems. So if you've got a patient that appears drunk, but say has normal alcohol levels, or say they've not drank alcohol at all, then you need to consider ethylene glycol or methanol poisoning. The antidote is fomepizole, which is an inhibitor of the alcohol dehydrogenase. So the way that these cause problems is because of the metabolite that's formed as they get broken down. But what the fomepizole does is prevents the formation of these toxic metabolites, and they can just be excreted out. Ethanol is the other one that you can use, so you can just give them some alcohol. Sodium bicarbonate is just to help reverse the metabolic acidosis. And then again, our trusty friend, hemodialysis in the very, very severe cases. Paraquat poisoning, again, very, very uncommon in the UK now. It was a weed killer, but it's now banned because of how toxic it was. The way that it works is it gets transported to the pneumocytes in the lungs, and forms free radicals and just destroys the lungs, basically. The key bit of information with paraquat poisoning is that oxygen is a contraindication to paraquat poisoning. If you give them loads of oxygen, you're just going to form more oxygen-free radicals and make them worse and kill them quicker. So if that does come up in your exams, it's one of the very, very, if not only, contraindication to giving lots and lots and lots of oxygen in hypoxic patients. Generally, people who are unstable after they've ingested a large amount of self-induced poisoning of paraquat should be palliated, because there's no real reversal of it. The aim of management is early decontamination, hemodialysis. If you're a little bit too far beyond that, then palliation is generally the only way, unfortunately. In children, say as such as 5 mils can be fatal. You're very unlikely to see it, but it's come up in exam questions before and past med, so just be aware of it. Organophosphate poisoning is again another one you don't see that often in the UK, but you may very well see a little bit in some of the developing countries. If you're going on your elective, you may very well see this. It's a little bit more common in insecticides in developing countries than it is in the UK. It was also used in sarin gas, one of the chemical weapons. The way that it works is displayed in this lovely little image, and it inactivates the acetylcholinesterase, and you get this massive surge of acetylcholine because it's just not been broken down. So you get essentially the opposite of a tricyclic antidepressant overdose. You get this salivation, you get diarrhea, you get pinpoint pupils, and you bradycardia. Whereas if you remember with the anticholinergic effect, you get the dry mouth, you get constipation, you get dilated pupils. So this is the opposite. And you'll also get profuse bronchial secretions as well. So the management of the organophosphate poisoning is atropine. That's the main one that will come up in your exams. That helps with the bronchial secretions. And this is it works as an anti-muscarinic. That's how it works. The other one that you may very well see is this that I can't pronounce, but essentially it reactivates the cholinesterase to then break down the acetylcholine to make sure that the neuromuscular junction then works normally. Cyanide poisoning is another one you will see. I popped this image up there. This isn't necessarily what cyanide poisoning causes, but if anyone has watched Skyfall, James Bond, the villain in it states that this is what hydrogen cyanide does to him. So that's why hence the picture. Cyanide poisoning works by inhibiting this cytochrome oxidase. Basically just stops cellular respiration and just kills cells. You need to be really, really careful with cyanide, because if you get hydrogen cyanide, it can cause death within minutes. So if you've got cyanide and you're inhaling it, you've got hydrochloric acid in your stomach. So if that cyanide mixes with the hydrochloric acid, you will get hydrogen cyanide. So if you get a patient with potential cyanide poisoning that's, say, vomiting or there's fumes, you need to be very, very, very careful and wear protective PPE. Ingestion may slow its effects due to the presence of food, obviously. So yeah, be very, very careful with cyanide poisoning. Clinical features: rapid loss of consciousness, pulmonary edema, headache, this classic smell of bitter almonds on their breath, which I'm guessing no one has ever smelt, but that's the classic you will see in the textbooks. It's reasonably common in house fires, is cyanide poisoning. So you get it when like melted plastics and things. So if you've got someone coming in with massive burns, be aware they may very well have cyanide poisoning as well. The treatment of it is with hydroxycobalamin. You give 5 grams stat, and then you follow that up with sodium thiosulfate. These two are generally the mainstay of treatment. You may very well see this dicobalt. Again, very effective, but it can be fatal without the presence of cyanide. So you need to be sort of 100% sure that the patient has cyanide poisoning before you give it. Whereas the top two, if you're suspecting cyanide poisoning, for example, in a house fire, and the clinical picture fits, you could potentially give these without any real problems. So coming towards the end, just a couple more slides. Carbon monoxide poisoning. You will all know that carbon monoxide is got a really, really high affinity for oxygen the HB compared to oxygen, which obviously then results in tissue hypoxia because the oxygen isn't on the hemoglobin, the carbon monoxide is, and aerobic respiration, hence an increase in lactic acid. You'll note that smokers, long-term smokers, will have a baseline carbon dioxide level of potentially around 10%. That doesn't mean they've got carbon monoxide poisoning as such, acute poisoning. That's just the way that their carbon monoxide levels will sit because of their long-term smoking. Clinical features depend on what percentage of the hemoglobin is saturated with the carbon monoxide. You start off with this really vague headache, tachycardia, confusion, which then progresses quite quickly into your comas, arrhythmias, and death. The treatment is very simple. You just give them 100% oxygen, high flow, for around 24 hours or until they're asymptomatic. That's the only treatment for it. There was a note that there could be a role for hyperbaric oxygen, which is given 3 times atmospheric pressure of oxygen. Don't know what the evidence base for it is, but I was reading somewhere that it could potentially decrease the half-life of the carboxyhemoglobin from 6 hours to 24 minutes. So potentially could be very, very useful. So that comes to the end of everything. I've put this little table up that you can screenshot by all means as a bit of a summary of the things we've spoken about, with the poison and the antidote next to it, just for very, very quick reference for exams. I'll give you a minute if you want to screenshot that. And then that's it. So has anybody got any questions for me? I'll stop sharing my screen. If anyone's got any questions, by all means, just shout out or type them in the chat if you want. If you've got any questions about any of the antidotes or clinical features or anything, I'm more than happy to help. Yeah, I'll just open the table up. That's fine. 2 seconds. Share entire screen. Bear with. There you go. I'll leave that up on there.
I'm happy to send it through as well. So thank you, Cameron, for this. I'm
That's
going
all right.
to share the QR code. Obviously, these sessions are very, very useful for us, and Cameron has kindly agreed to do it, but obviously we'll want to help him out with his portfolio as well. So it would be really appreciated if you guys fill out the QR code and give us a bit of feedback. We do have a session tomorrow at the same time. We've posted on Instagram the topics we're going to be covering next week as well. We tried to cram in as many possible before fifth year exams, and we do appreciate you guys coming.
Yeah, thank you very much. Unfortunately, the feedback never stops, even once you've finished medical school. You'd be asking people for feedback for the next 20 years.
Yeah. The link for tomorrow's session I'll send out. It's in the fifth year and fourth year group chats. It's also on our Instagram in our bio. We've got a massive link for all the talks. So you can access it through there. I'll be sending it around.
Thanks very much, everyone. Hopefully see some of you tomorrow and next week. So we're going to try and cover most of the acute care block in the next couple of weeks.
Yeah.
Hopefully it will be useful.
Would it be okay, Cameron, if we post these recordings to YouTube for those who couldn't access it or couldn't make it today?
Absolutely
Fantastic.
fine. Not a problem at all.
Thank you. So it will be useful for people to kind of recap as well.
Yeah, absolutely. Yeah.
Thank you.
All right.
I'll stop recording.